lesions, ulcerations or erythematous lesions, leukoplakias, etc. The oral cavity, as we know, consists of dentition, 32 teeth in the adult, 20 teeth in the child. The basic anatomy, I'm sure you're familiar with, but it's important when we examine patients that we look at all of the soft tissue, so gingiva, lips, palpate the lips, examine the buccal mucosa. It's good to stretch the buccal mucosa a little bit to see if there's a lesion under the soft tissue. The submucosa, vestibule, hard palate, soft palate, tongue base, floor of mouth, lateral borders of the tongue are all key areas to examine. Thorough head and neck exam always includes palpation of the lymph nodes in the preauriculars, tonsillars, submandibular, anterior cervical, posterior cervical. And you may pick up, as you know, lymph nodes.
Alex, we're having a little trouble picking up some of your audio, so maybe get a little closer to a microphone or increase.
Okay. Stand up pretty high. You hear me better now?
We'll give it a shot. Thank you.
Is that better?
Yeah.
Okay. Palpation of the neck should be bimanual. Other examinations that general dentists usually use, the oral surgeons don't use these as much, but for rapid screening of patients, tissue fluorescence using fluorophores, using special lights are commonly used by general dentists. You can see they help to light up areas of increased metabolic activity in the oral cavity, which may represent precancerous lesions. So commonly the general dentist will send us patients after finding these spots from a fluorescent exam. They're not very specific, but you will pick up some cancers sometimes. These are just some views of that. Benign soft tissue lesions can be the result of infections, bacterial, can be endodontic, periodontic from the root canal or the gums. Viral can be herpes simplex, HPV, HIV, for example. Fungal, candidiasis, aspergillosis, mucormycosis. Candida, of course, is very common. Aspergillosis, mucor are quite rare. Anug, or acute necrotizing ulcerative gingivitis, we still see from time to time from very poor hygiene. It's called Vincent's infection. The patients will come in with sort of punched out lesions of the gingival papilla and in a lot of pain. Here's an example of a chronic candidiasis. It almost looks like a precancerous lesion. It was biopsied and came back as no evidence of dysplasia, but a heavy candida, which was treated both topically and with metronidazole. Herpes simplex viruses, you can see the flat macular, papular kind of lesions in crops or in clusters, very common, often associated with fevers and a lot of pain. It's also called hepatic gingivostomatitis. HPV lesions are these flat type of lesions. They can be solitary, they can be multiple, they can be in carpet form, especially in patients who are HIV positive and untreated. They can be quite indolent. We know that HPV is associated with increased oral cancer, especially in the United States. We're seeing increased head and neck cancer cases related to young people with HPV. An uncommon lesion is the verruciform xanthoma. It has an appearance similar to a wart or verruciform lesion. It's kind of cobblestone in appearance. They're small lesions. They can be difficult to completely eliminate. Sometimes it requires multiple procedures to excise these. Sometimes laser is helpful. It's a benign lesion. Inflammatory lesions such as lichen planus, vesicular bullous, pemphigus, and pemphigoid lesions, ulcerative lesions such as aphthay or traumatic lesions are, of course, very common. Lichen planus, you can see the striae of Wickham, a very common lesion, posterior buccal mucosa. It can be in the gingiva, in the gingival tissues, down on the tongue, It can be found throughout the mouth. It can be mild, moderate, severe. Patients may often have cutaneous lesions, especially palmar lesions are quite common. We treat it usually with steroids, topical, injectable, sometimes systemic. Sometimes these lesions are caused by reactions to toothpaste. So sometimes you have to tell the patient to go with a very plain toothpaste without a lot of additives. Surprisingly, this lesion, while it looks like it might have been a precancerous lesion or a dysplasia, in fact came back as lichen planus. So here you can see lichen planus in the soft palate. Vesicular bullous lesions, you can see this blister-like lesion on the hard and soft palate. This can represent pemphigus or pemphigoid lesions, or it could just be a non-specific lesion. Biopsy early is advised. You can look for Zank cells by the pathologist, helps to confirm the presence of pemphigus. Aphthous ulcers, of course, very common. Here you can see an aphthous ulcer of the mouth. Usually traumatic, but they can also be spontaneous. Usually treated with topical steroid pastes. Sometimes you have to excise them. Non-aggressive benign soft tissue tumors, commonly seen irritative fibroma, papilloma, mucocele, pyogenic granuloma, granular cell tumor of the tongue, hyperkeratosis, epithelial hyperplasia, leukoplakia, xanthoma, are benign lesions that we commonly see. So we call them oral lumps and bumps. Hard and soft tissue lesions. Fibroma can appear in many places in the mouth, usually from biting, from the teeth. It can be in the lip. It can be in the tongue. The buccal mucosa are common sites. Also be in the gingiva. There's another fibroma associated with Wharton's duct. You can see a lacrimal probe into the duct associated with the lesion, so you have to be careful, for example, when you excise one of these. Surprisingly, this erythematous lesion came back as an irritative fibroma from biopsy. It's in a bad location at the attached gingiva at the cervical margin of a tooth, so removal of that requires a flap that has to be brought down, and these heal quite well. Gingival cysts, very common in the gingiva, usually in the interdental space of the gingiva, usually on the buccal aspect of the mandible. They can appear bluish. They're not hard, they're a little squishy or soft. They're easily excised. Papillomas here in the uvula, we can see several papillomas. It's a common site for papillomas, and sometimes they can be dysplastic, so that it can be important to biopsy them if you're suspicious. Mucocele, common bump in the mouth. Here in the floor of the mouth, this came back as a mucocele, surprisingly. Here, of course, is a large one in the lower lip, buccal mucosa. Another one in the lower lip itself. They can be quite disfiguring, and patients usually want them removed. Here's another mucus retention cyst, hard palate. The hard mid palate has lots of salivary glands, commonplace, especially in smokers. Necrotizing sialametaplasia is a completely benign disease. It looks bad. It looks like it could be a tumor or cancer. It's generally in the mid-hard palate. In the past, patients often had aggressive surgery for these. It's completely unnecessary. But you can see the multiple lesions that can appear and the rind that forms around them. These can be very firm, papular kind of lesions. Again, completely more of the same. Focal melanosis, very common. We see melanotic papules or foci in the mouth. Pigmentation in the oral cavity, very common, especially in individuals with pigmentation. Here's a patient with a lot of pigmentation in the gingiva. Of course, this is completely benign. Leukoplakia or white lesions in the oral cavity, very common. Here on the lateral border of the tongue, you see a diffuse type of leukoplakia. This can be suspicious. It has an irregular surface and should be biopsied if Here on the dorsum of the tongue, again, another leukoplakia common in smokers. This may be where the individual holds his cigarette commonly, a very common area. You can have very diffuse areas of leukoplakia. These may come back as just hyperkeratosis, but often benign. It almost has a striae of Wickham appearance in this one as well. Here again, an individual, you can see very extensive areas of leukoplakia. This is an individual who chews betel nuts. They can be precancerous, so you have to be careful and consider biopsy where suspicious. Here is a leukoplakia of the hard palate. Again, you can see how it has a hyperkeratotic area and a macular appearance. Pyogenic granulomas appear between the gingiva. They're often soft, well-rounded lesions. Excision has to extend deep into the periodontal ligament or they recur. Here is another pyogenic granuloma of the hard palate. They can be traumatic in origin. They present in ways. Hemangiomas are very common lesions in the oral cavity. They can appear as flat lesions. Capillary hemangiomas, such as this one. Rarely a cavernous hemangioma can be present, especially in the bone of the mandible or the maxilla. This again, a hemangioma, you can see the venous nature of the lesion. It's exophytic. Here it's easily removed. Under the surface of the dorsum of the tongue, again, a hemangioma that came back from biopsy. It almost looks like a granular cell tumor. Here is another hemangioma, the hard palate. In the hard palate, raised dome-like lesions, we always have to be concerned about salivary gland malignancy. So we have to usually biopsy these if they're persistent. Lymphangioma can appear. Here's one that appears almost like a fibroma, but not as more blended into the soft tissue of the lip. And it's disfiguring, and patients usually removed. Granular cell tumors of the dorsum of the tongue are benign lesions and easily removed. They can be vascular, and sometimes it's wise to remove it with a laser. Schwannoma, common, not a common tumor, but they are present in the oral cavity. Here in a young fellow, 9 years old, we see a large lesion of the tongue. You can see how it expands in the dorsum and the ventrum of the tongue. On removal, we can see the extent of this. They can be quite large. Salivary gland disorders can be mistaken for benign mesenteric hypertrophy, bilateral mesenteric hypertrophy. Nothing to do with parotid disease, but it can look just like bilateral parotid hyperplasia. Ranula or mucus retention cysts, they can be quite large. Here's a very large one that was a life-threatening emergency. Patient taken to the OR, raised tongue. Fortunately, it was anterior and not an airway risk. It was drained bilaterally. The young man did well. Silolithiasis is often associated with or salivary calculus. Here is a Wharton's duct, anterior floor of the mouth. We can see a stone that has migrated anteriorly. Once the incision is made, we can see the stone appear, and here is a pretty large stone that has been displaced to the Wharton's duct from the these stones can be quite large, as you can see here, and this patient had to have bilateral submandibular glands removed. You can see the scar from the first one, and you can see he has another one that here's the gland being removed. Here you can see a very dilated submandibular duct. There can be huge dilations of these ducts, and you have to cut it and tie it off when you're removing the gland. As we know, there are several nerves of concern when we remove the submandibular gland, the marginal mandibular branch. The patient nerve of the facial nerve, the lingual nerve to the tongue, and the hypoglossal nerve are all in the same. And these vascular ties are around those structures. Here we can see the excised gland, very diseased, very nodular from chronic sialadenitis. Here you can see a very large stone, almost benign aggressive hard tissue lesions. Exostoses or tori are very common. They're usually painless, but they can get quite large. They can be disfiguring. They can begin to develop ulcerations and have to be removed. Here we can see a very large buccal exostosis beginning to disfigure the patient. You can see the mass beginning to appear in her face. Here she is post-op after the removal of the lesion. Here we've removed the lesion. You can see on CT, again, you can see how large these cortical benign tumors can be, and they are completely benign. Rarely they will be at the inferior border of the mandible and become disfiguring and have to be removed. And in a coronal view, you can see these buccal exostoses. And we just remove it. Here's a removal of a large inferior border osteoma. Here you can see the young lady had a large inferior border osteoma that was growing quite rapidly. Here you can see it's beginning to disfigure her. In the three-quarter view quite well. Again, very disfiguring in a pretty young woman. Here's the normal side. Here you can see on the CT the lesion. It grew within 9 months quite substantially. Here again in this view. Using VSP or virtual surgical planning, we determined the amount of bone to be removed, where we wanted to excise it. The excision must extend into the marrow space where these lesions can recur. Here we mirrored the sides so we would know what the normal side should look like. We created a cutting guide so that we could do this completely intraorally to avoid an external incision. There's a 3D model with the cutting guide that we would use a oscillating saw at 90 degrees to excise take the incision into bone. Here's the guide screwed into place. You can see the slot to place the oscillating saw. Here's our specimen removed, quite large, 5 centimeters. Matches up with our surgical plan. Here we see the patient. We can see where we excised the tumor. Post-op, she had a wonderful result. She looked terrific. A very happy patient. Much improved aesthetics. Compound odontoma is another type of benign tumor. These are known as rice teeth. You can have multiple small teeth that are formed with this tumor. You can have as many as 50 or 60 small teeth. Branch or hemorrhage is a disease of the maxilla or the mandible associated with bisphosphonates. This patient had teeth removed and it's had poor healing and a near pathologic fracture of the mandible. We went in and excised with a partial mandibulectomy. Here you can see the disease. And then a fibular graft was fitted together with our colleagues. And they did a free fibula for the patient. Odontogenic cysts and expansile lesions. These are very common lesions of the jaws. Here on a panoramic X-ray, we see an impacted wisdom tooth associated with a large dentigerous or odontogenic cyst that has thinned out the mandibular cortices extensively, and this patient could easily have a fracture of the mandible that's pathologic. There's a large maxillary cyst, again, associated with old hardware from prior jaw surgery. Again, very destructive into the floor of the nose, completely into the palate. Usually we like to marsupialize these by placing a drain tube into them that reduces the size of the cyst. Here we've reduced it through marsupialization. We've gone back. There's some old stainless steel hardware that we don't see too much anymore. Here's the lesion. We've removed the hardware. Here you can see the defect. It affected the teeth, so we did immediate root canals and root canal surgeries to seal them. Then used a combination of graft-on and infuse to pack the lesion with bone and cover it with a layer of infuse. As you can see, post-op, really nice bone healing. We salvaged the teeth. Patient's happy. Nasopalatine duct cysts can be quite large. You can see this is a huge lesion that's eroded into the anterior nasal floor, anterior maxilla, and you can see very large lesion and very destructive. You can see the anterior palate that's been damaged. Intraoperative, you can see the lesion here, and we've nucleated it. It went up into the nasal floor, ate away part of the nasal septum, put in some methylene blue to burr down, so we've removed all of the residual epithelium. We took a block graft from the hip, creating a strut for the nasal septum, anterior nasal septum. That's reconstructed, and then we pack bone. Defect, here we see that we also did root canal surgery. The bone has regenerated nicely, as we can see here. Keratinizing odontogenic tumor, or Gorlin-Gold syndrome. Here's a man with extensive disease, many large cysts of the jaws associated with placed teeth. This patient removed about 20 of these cysts over time, removed many of these teeth. Here you can see the extent of the damage in the maxilla, for example. Here's the specimen. We can see the histology, typical parakeratinizing layer of the keratinizing odontogenic tumor, which has a high recurrence rate. Benign aggressive odontogenic tumors, such as ameloblastoma. Here we can see this blue dome raised lesion of the lingual aspect of the anterior mandible. Here's a patient in the anterior maxilla with a lesion. You can see how the teeth are placed as a result of the tumor. Here we can see the honeycomb appearance in the maxilla, and this is a true ameloblastoma. Here's the histology. We see the palisading cells that are basophilic in nature associated with the stroma and fibrocollagen tissues. Here we have resected a lesion that we showed before with penetration into the sinus as a block excision. Here's the specimen. Went to the hip and took a large block from the hip, about 4 by 3 centimeters, and we screwed it into the underlying maxilla, which also helps close off the sinus and prevent an oral-antral communication. This healed really well. You can see the bone completely healed, no sinus communication at all. And if the patient wants dental implants, he can certainly have them with that bone, which he has declined so far. Here again is the reconstruction. We can see here. This is a triple lesion, very unusual lesion, an ameloblastic fibroma. 11% of these will become sarcomatous, so we have to be more aggressive in terms of resection. In this lesion, we had a impacted tooth with a odontogenic cyst associated with our ameloblastic fibroma, and we had a compound 3 lesions. Here we can see on the scan here the expansion and damage to the mandible. We did a local resection and harvested a large block of hip, inserted with rigid fixation. You can see we got good height of the bone with compression under the bone plate. The graft was successful, but we wanted more augmentation for dental implants. So we did a tibial plateau graft where we harvest bone from the head and laid it down with mesh coverage. Here we used CT surgical planning for the dental implants with a surgical guide. You can see the implant plan into the graft. And is the surgical plan with the stents. Here's the surgical guide that goes in the mouth. We drill into the jaw and we place 3 dental implants. Furthermore, there was a cosmetic defect at the angle for this patient. So we used a piece of med pore that we carved and placed it intraorally to rebuild the angle of the mandible. Here he has 3 dental implants that have been successful for about 13 years now. Myxoma is a unusual lesion of the jaws. Again, very aggressive lesion, completely benign, but very aggressive. You can see the damage here in the anterior mandible. He runs 3D CT, damage being caused by the lesion, the inferior border still intact. Here's the histology showing the comatose nature of the lesion and the high level of collagen fibers present. Here is the tumor. We can see a very large mass in the floor of the mouth expanding into the buccal. This gentleman obviously walked around with this for a very long time. We made an intraoral incision on the buccal and the lingual, trying to closure. We identified the mental nerve, which was preserved. Here's the surgical specimen moved. You can see the size of the tumor and its expansion. We preserved the mental nerve bilaterally for the patient. And then we took a large amount of block bone from the hip, harvested from the intertable. The graft is laid onto the basal bone, screwed into place. There's a closure, so we had no exposure of bone from the oral graft. Here we can see a nice consolidation of the graft and good long-term bone healing. Here's a rare tumor, a tenosynovial giant tumor of the right glenoid fossa and skull base, picked up in my office as a TMJ complaint. We can see the tumor here in the glenoid fossa. Intraoperatively, working with neurosurgery, we removed the right temporal bone, full thickness, excised the glenoid fossa into the middle cranial fossa, shy of the jugular and carotid vessels. Involved. That's the tumor removed. We split the lateral, we split the temporal bone and created a new glenoid fossa. So here we built the glenoid fossa for the mandible, brain tissue, and then we put the rest of the bone flap back into place. So you can see there's like a right angle junction between the bone flap and the new glenoid fossa. Benign tissue, soft tissue tumors can be precancer, such as epithelial dysplasia, mild, moderate, severe, and carcinoma in situ. Dysplasia commonly as an actinic hyperkeratosis in the lower lip from sunlight exposure, commonly seen, should be biopsied. Here we can see a irregular leukoplakia lateral border of the tongue, suspicious and should be biopsied. Came back as a dysplastic lesion, which was then treated with laser. You can see the SCHAR. Squamous cell carcinoma, again, commonly appears in many different areas of the mouth. Here in the maxillary sinus, the tumor was fungating through, involving a tooth socket. So a loose tooth is commonly associated with these types of tumors and should not be ignored as a symptom. Here's a verruciform carcinoma spreading along the aspect of the mandible. Other squamous cancer here. Again, in the tooth socket, a socket that doesn't heal. Sockets that don't heal should be considered as suspicious for malignancy. Here's the patient having the tumor removed with a island flap from the segmental region drawn to close over the defect. Another submental island flap, same thing for a patient with mouth tumor, is very aesthetic. Chondroblastic osteosarcoma, rare. The old Andy Gump deformity, of course, is rare today given free soft tissue transfer techniques. There's a patient with a suspicious lesion of the right mandible. The patient had an expansile lesion, but we see some the bone. Patient had a loose tooth, had paresthesia and pain along the distribution of the inferior alveolar nerve, was missed in an ER for about 4 months before presenting to me. See the diffuse lesion in the bone. Here is the biopsy specimen. We can see the chondroblastic cells widespread in the tumor. She underwent surgery with a radical neck and partial mandibulectomy. Here you can see the mass. Here you can see the prominent vessels of the neck, intraoral exposure of the tongue. Here's the mandibular defect, bridged with a fibula graft and immediate placement of dental implants. Here you see the dental implants and the restoration. This patient's done well for about 13 years now, free of disease. Fibula grafts, of course, are using new technology for harvest and cutting and shaping, and prefabrication of plates. Here, osteosarcoma. Here's an osteosarcoma of the maxilla. It was associated with a root canal lesion. The surgeon did a root canal surgery, was suspicious, took a biopsy. You can see how the mass is growing into the space of the maxillary sinus. She had the tumor excised, immediate scapular graft, and later placement of dental implants. Here's the reconstruction. Salivary gland cancer, mucoepidermoid carcinoma of the hard palate, often a bluish lesion. They can appear in different parts of the mouth. Here you can see the mass on a model. Here we're in surgery. Tumor excised. They have a very low malignant spread or recurrence, and this is generally curative when they're removed. A palatal stent is made and helped with some screws for patient comfort. There's another patient, similar mucoepidermoid lesion, tumor removed. So I've tried to give you a bit of an overview of common oral pathology lesions. I thank you for your attention. If you have any questions, feel free to ask. I have a few minutes here.
Alex, I always thought that otology had a lot of terminology, but oral surgery has not only a lot of terms, but a lot of different pathologic entities that make it up. Frequently we'll see lesions in the ear canal that, they'll come back like granulation tissue, but yet we have suspicious for cancer and we go biopsy it, and then, we'll get our diagnosis. Let me ask you a question. With oral cavity lesions, do you run into that same thing? Having to rebiopsy?
It's less common. It's less common that you need to rebiopsy. It's usually pretty definitive the first time around, just because we have such ease of access.
Mm-hmm. Mm-hmm. In New York City, are there a few specialists in oral pathology at some of these institutions?
Yeah, we have them around at the major institutions like Mount Sinai and Columbia, for example. They're very good oral pathologists, and we do a lot of work with them.
Mm-hmm. You showed a picture of some beetle nut exposure. I've had some experience with beetle nut, especially in the Northern Marianas, Saipan, Yap, in the Pacific Rim area. Beetle nuts they're well known to cause, to be carcinogenic, but people still, they'll chew the nut and then they'll take lime from coral and they'll grind the lime up and chew and put it in their mouth to stimulate the juices from the beetle nut. Do you see much beetle nut exposure in New York City?
Well, we have a large Indian and Pakistani population here in New York. So we see a fair amount of beetle nut chewing, and it often presents in patients who have submucous fibrosis and difficulty opening the mouth. So sometimes these patients have very limited jaw opening, and it's impossible to reverse. I mean, it's very, very difficult to treat submucous fibrosis.
Mm-hmm. Are you still seeing a lot of tobacco chewers, or is that kind of, people are in the United States, fewer people are smoking cigarettes. Have they also diminished the use of oral chewing?
Actually, I have a large number of young men who smoke, who use smokeless tobacco or chewing tobacco, and they tend to develop mild dysplasias and sometimes in multiple sites. They're often drinking alcohol. It's very, very difficult to get them to quit. And they sort of look at me as, well, I can go and see the doctor and he'll tell me I'm okay, and I can go back and use my chew and drink, and it's an interesting set of people.
Mm-hmm.
and as much as you scare them, it doesn't seem to do much.
All right, does anybody have any questions? Please feel free to unmute yourself. And
Hello.
okay, Martha.
Hello.
From Spain.
Yes, hello. I have one question for Dr. Alex. Thank you for your speech. And I did my PhD, my doctoral thesis on oral cancer like 15 years ago. And I researched about the HPV virus in these local lesions. And at that time, we didn't have much incidence of this virus in these lesions. But anyway, nowadays we are seeing as well a lot of oropharyngeal cancer related to HPV. And my question is, what do you recommend to these patients about the vaccine? In Spain, the vaccine is mandatory for all children, for all 12 years old girls, not boys. And for sure, these patients that are having now these tumors, they are not vaccinated because we started this vaccination. I think the policy started like 7 years ago. So all these adults having these tumors, do you recommend them the vaccine despite they have already developed the disease? I would like to know your opinion.
Well, I mean, the HPV vaccine is very helpful, for, preventing infection throughout the body. I mean, once someone already has HPV, I don't know that the vaccine is necessarily beneficial. I don't know enough about it to say. But, it's worth perhaps looking into. Here, it's mostly the pediatricians administering the HPV vaccines. It's rare to get adults to, to have it, but maybe in higher risk populations, it's being recommended now. I can't tell you specifically.
Mm-hmm. Yeah, because this is always a question, no? They don't know exactly which is the benefit of those patients having the vaccine or not. But I always ask myself, if I will have this disease, will I get the vaccine? I will probably say yes, because who knows what's in the future. But I would thank you for your answer.
Thank you very much.
Yeah,
you're welcome.
Since yesterday, Sputnik 5 came out. You guys know what Sputnik 5 is?
Mm-hmm.
Sputnik 5 is the vaccine from Russia.
But that's for COVID.
Exactly. But the thing is this, they only tested 10 people. They only did phase 1 studies. They didn't do phase 2, and they never did any phase 3. So it's going to be very interesting to see what Sputnik 5 has to do other than go to outer space. Okay. So anyway.
Putin's daughter got the vaccine, so that's an extra plus of security thing.
Yeah, I don't really believe his daughter got it, but wait until you start seeing the black market for Sputnik 5 come. Okay, we're going to start selling it in the black market, and people are going to buy it. Well, listen, I think I'm glad I didn't become an oral surgeon. It's not my dig. It was an interesting lecture by all means, Alex. We definitely appreciate it. I think
Richard.
Yeah, Nestor, please go ahead.
Before you say goodbye to Dr. Alex, I would like to ask something.
Yeah, please go ahead. Nestor's from
Sure.
Paraguay.
Hi, Dr. Alex. Very
Hello.
interesting lecture. I'm very glad to be able to watch your lecture, and I would like to know if you had any information, because here in South America we had a custom, we normally have some beverage infusions with hot water, mate tea with hot water, and there is some evidence that it affects the esophagus because of the hot water. And it, for example, in Uruguay, they had a lot of esophagus cancer because of the thermal reaction of the mucosa. Have you do you think is it possible to have an effect in the oral mucosa as well, or have you seen any of these lesions?
En Nueva York no tenemos muchos para beber mate con la bombilla,
Okay.
pero es posible que agua muy caliente no está bien por la mucosa de la cavidad oral y bucal.
Okay, Alex, for those that don't speak Spanish, please translate.
Okay. What I'm saying is we don't have many patients who drink mate necessarily in New York. There is an Argentine population here. I can't say that I've come across that particular group as having an increase in oral cancer related to consumption of mate. Perhaps they become Americanized and they're not drinking it quite as piping hot. But perhaps it's out there.
For those that don't know what mate is,
Thank you very much.
mate is the leaf of the plant.
Hello. Before we finish, Prof, can I ask a question for Prof?
Yeah, hi, Aziz here from Somalia.
Yeah.
Okay, Aziz.
Thank you, Prof. We have here in Somaliland, Somali people who eat cat, and what I have seen is that although I did a study, but I have seen some of the cat too is developing some pemphigoid-like lesions in the oral cavity, and then when I gave them steroids, because I don't have a good pathologist here, so when I gave them steroids, they responded. So is there anything that they can say about the pemphigus and the material of use?
Well,
for example, cat.
I mean, you're asking about pemphigus, yes?
Yeah, I'm asking about pemphigus, yeah.
I mean, pemphigus is usually treated as a systemic disease with high-dose steroids. It can be quite deadly, as we know. Sometimes it's very mild. It depends on the clinical manifestation in the patient. Biopsy is often very diagnostic. You can use immunofluorescence studies to help pinpoint it as well. But biopsy is usually essential. It's often a medical entity that the physicians sometimes have a hard time diagnosing. And sometimes, we're the ones that make the diagnosis for them. And dermatologists.
All right, does anybody else have any questions?
I thank you for your time. I actually have to get going because I have patients to see.
Nega from Ethiopia has one question. Nega,
Okay.
turn the volume on. Nega, we can't hear you.
Maybe he can email you the question and you forward it to me, Richard, if we can't hear him.
Yeah, Nega, we don't hear you. So, yeah. Go forward.
Can you hear me?
Okay, yes, we hear you now, Nega. Yes.
Richard,
Yes.
can you hear?
Yes.
Yes.
Nega. What's your question?
Yeah, thank you, Alex, for your nice lecture. How common is cankerem oris or noma in the United States of America, which is common in the undeveloped countries, and how do you treat it?
Noma is quite rare here. We don't see it like you would see it in Ethiopia and other parts of the world. It's basically, a bacterial disease. It's usually, unfortunately, associated with, lower levels of hygiene and sanitation and diet. We don't have much experience with it. I know that the treatment is usually very aggressive, surgically and with antibiotics. And often for the very, I've seen of patients, who've lost entire lips as a result, who've needed reconstructions, in which it's called cankerem oris, in that form of it. But we don't have much experience, I have to say.
Okay, thank you.
All right, well, listen, everybody, thank you for your questions. Alex has to go pull some teeth. That's what he does for a living. And
Okay, everyone, any other questions?
if there's no other questions, Alex, thank you very much. We appreciate your time. And if anybody does have a question, please put it on the form and and we will.
Richard, and get back with patients.
Yeah. All right. Listen, Alex, thank you very much. Everybody have a good weekend and stay healthy. All right. We'll talk to you soon. Bye-bye. Thank you, Alex.
Thank you.
Okay.
Bye.
Yeah.